Good afternoon, and thank you so much for joining today's forum, Maternal Health and Mortality. Next slide. I am Dr. Tasha Green-Cruzat. I'm the president of Children's Advocates for Change. I am also a board member. This organization, Children's Advocates for Change, is an independent, nonpartisan advocacy organization that is committed to the well-being of every Illinois child, and we champion those policies and investments for children, for them to be educated, healthy, and thrive. Next slide. Just want to do a little bit of housekeeping before we start. I just want to remind everyone that your microphone will be muted. Please place any questions in the Q&A box. The chat box will be open for you to make comments, to post links. We definitely want you to be engaged in this conversation. So please feel free to use the chat box, but we ask that you put your questions in the Q&A box. Today's webinar is being recorded. It will be available for playback following today's event. Next slide. This forum was sponsored by the Helen and Maurice Weigel Fund, Northwestern Medicine, and Johnson & Johnson's healthcare system. So thank you very much for sponsoring this important discussion today. Next slide. Our panelists today, we have first Vernice Anthony. She is the CEO of VDA Health Connect. Her career includes serving as the City of Detroit's Public Health Department Director and as Director of the Michigan Department of Public Health, where she provided leadership for infant mortality programs, resulting in reducing infant mortality rate in Michigan. She also serves as CEO of the Greater Detroit Area Health Council, where she created the Southeast Michigan Perinatal Quality Improvement Coalition in partnership with the Michigan Department of Health and Human Service. Next, we have Kylie Lanalise. She is the assistant professor in the Department of Human Development Nursing Science at the University of Illinois at Chicago. She has a PhD in anthropology and is a certified nurse midwife. Her current research focuses on health system structures and racism that drive disparities in maternal morbidity and mortality. This project is designed to assess the implementation and impact of a culturally adapted and patient-centered model of maternity care, inclusive of broad structural changes to attenuate the impacts of structural racism. And last but not least, we have Laura Mayer. She is a certified nurse midwife and an advanced practice registered nurse. She has over 27 years of practicing as a certified nurse midwife. She is employed by Avilio Medical Center and has hospital privileges at Mount Sinai Hospital in Chicago. Next slide. So in order to be able to really level set this conversation, I want to make sure that we all are on the same page in terms of what is maternal mortality. So when we talk about it, what is it that we mean? And so Children's Advocates for Change uses the Illinois Department of Public Health definition, which is pregnancy-associated death, and that's death of a woman while pregnant or within 1 year of pregnancy from any cause. It's also a pregnancy-related death, a death of a woman while pregnant or within 1 year of pregnancy from a cause related to pregnancy. Next slide. So as you can see here, these are the US maternal mortality rates, and Children's Advocates for Change spent some time sort of looking at some of the rates nationally, but also some rates within Illinois. But I think it's important to point out here that the rates in 1915 to about maybe 1921, you can see that there was a stark, rise in maternal mortality rates. But then it started getting better and better and better, and there was some progress being made, from those rates, sort of bringing, driving that down. And I feel that there has been some great strides, but I think that we hit, a serious bump in, as, approaching into the 1990s, where we see that you started to see the mortality rate started to trend upward. And so the Commonwealth Fund believes that the focus has been probably mainly on hospitals and not so much on community-based care. And so we're seeing these numbers, rise up. We were seeing some great progress, and then there was this shift. So I think that it's important to understand kind of where we have been historically, and how we are sort of moving into a different space. Next slide. So the US mortality rate data here is disaggregated by race. And as you can see here, that since the late 1940s, the number of Black maternal deaths per 100 live births have been 3 to 4 times higher than the number of white maternal deaths, and that's per 100 live births. So as you can see, these stark differences here, and this is a reason for us having this important conversation, is to really get to, what is it, why are we, having these problems, especially, when you hear, reports from the CDC saying that these deaths, these are preventable, right? That we can do something about it. And if that's the case, why do we see this vast disparity when it comes to maternal mortality? Next slide. And so here, I just wanted to take a moment and just point out some of the national data compiled by the Centers for Disease Control and Prevention that really shows the top underlying causes of pregnancy-related deaths. As you can see here, when you talk about just sort of like the total, the underlying, cause is mental health conditions. And when you disaggregate that data by race, the top underlying cause for Black women is cardiac and coronary conditions. And for white women and Hispanic women, the top underlying cause is mental health conditions. And for Asian women, it's hemorrhage. Next slide here. So we're going to get into we can go ahead and take the slide off, because I want us to get into now this conversation that we need to have about disparities. And we have our wonderful panel here to have this conversation with us. And so I'm going to ask, point our attention to Ms. Davis Anthony. Vernice, good morning, and thank you for being here and part of this panel to have this very important discussion. So you are the CEO of VDA Health Connect, whose career has included working as the City of Detroit's Public Health Department. You were the director there and the director of the Michigan Department of Public Health. And as we saw in the slides, since the 1940s, the ratio of Black maternal deaths per 100 compared to white maternal deaths per 100 has generally ranged 3 to 4 times higher than that of white maternal deaths. So I want to get your opinion in terms of the reason for persistent disparities in the maternal mortality rates.
Okay, well, thank you. I'm glad you used the word persistent, because while we have seen overall decline, which is now going back up, the disparity has never really, that gap has never really closed. So when we see progress, you may see larger numbers showing progress, but not the disparities. And some of the reasons for that has to do with what we call social determinants of health, poverty, educational level, neighborhood, transportation, those kinds of things, which actually are all linked to systemic and structural racism in our country. So systemic and structural racism is based really on the history of our country. I mean, we were built, the country was built by free Black labor for hundreds of years. And that has gotten itself woven into many of our policies and laws and how decisions are even made, which is still in place today. And that is what impacts where we live. For example, Detroit has a long history or prior history of redlining, which still has impacts today when it comes to housing and where people live. And I know, all of the issues of segregation and discrimination still make a difference when you say the built environment or the neighborhood is one of those factors. So that is the reason, one of the primary reasons for the persistent disparities. Another primary reason that we now know and recognize is how healthcare is delivered in this country, particularly how healthcare is delivered to, and I'll speak to African-American women. Primary being not listening. When you can have a star like Serena Williams not be listened to, during her delivery, could have lost her life. Not listening, not doing the same level of examination, perhaps not examining or doing the proper diagnostic procedures, not following the same level of guidelines for, say, hemorrhage or hypertension in African-American women that we see in other women. So the current healthcare delivery system and the way healthcare is delivered today, then I would add to that implicit bias, the bias of providers that is at play in how healthcare is delivered. That's about an hour lecture in about 3 minutes. But those are the reasons why we see this persistent disparity in maternal mortality and increasing. Should be unheard of in a developed country.
Yes, thank you. And so you talked about the role of the social determinants, you talked about housing, you talked about the delivery system, you talked about community, which are all important factors here. Is there a persistent barrier to health care for Black women impacting the maternal mortality rate, or is it less access to care and more quality of care provided, or how a doctor handles complaints?
I would say all of the above at different levels. And it's not just how a doctor responds to complaints, is whether or not they even hear the complaints, or do they even listen to what a Black mother might be saying, as opposed to what a white mother might be saying. There's the how care is actually delivered in a different way. We know, for example, and I'm glad we have some midwives on this panel, that midwives and doulas, which are support people, when they're in play, Black women have better birth outcomes.
Mhm.
So it's not access to care, it's access to what? And when that care is delivered in community settings, you have better birth outcomes. There's even been a fairly recent study that showed that small, low birth weight babies that are delivered and cared for by African-American pediatricians have better outcomes than when they're cared for by white pediatricians. So it's all of the above. It's not access to care, it's access to what kind of care, where that care is delivered, and who delivers that care.
So thank you, Vernice. So in your experience, what do you feel the public health system is most lacking that has the most significant relation to maternal health, to maternal mortality?
Yeah, well, what the public health system is lacking, one thing I would say is the ability to lead, leadership. And public health is a department, but public health is a community, it's a process. It's, for example, what we like to say in public health is that there should be public health in all policies, housing policies, for example, transportation policies, for example. So it's not just what a department has, it's whether or not what we know about the public's health, particularly those most likely to be negatively impacted, which are minorities, are impacted by policies and decisions and laws that we make. So the lack of integration of public health across all systems. And there is a lack of resources, and that COVID dumped a lot of resources all at once in a couple of years. But then again, that was targeted to COVID, and a lack of the policy strategy and the politics of today's political environment has really damaged severely an already fractured infrastructure for public health. We are losing public health leaders. I don't recall the recent numbers, but a huge number of health officers, for example, in our state, left within the last few years, as well as nationally. And how are we going to fill that back in the future is a real challenge for us. So that would be resources, that would be the lack of public health integrated within all decisions, the lack of leadership. And this is not public health's fault, but the lack of public support and understanding of the role of public health in our communities.
Thank you, Vernice. You talked a lot about the public health system, and that's some really great information. I want to get your thoughts on how private and nonprofit hospitals handle maternal health.
Well, private and nonprofit hospitals, as you know, are the primary delivery site for deliveries in our country. In Michigan and probably in Illinois, too, there's a program called the Alliance for Innovation in Maternal Health, My AIM, Michigan AIM, probably Illinois has it also, where hospitals are encouraged to implement certain criteria and policies and procedures. They're called bundles around some of the major causes of death for maternal mortality, like hemorrhage, like sepsis, for example, hypertension, which is behind that. And we're trying to get hospitals to comply with that, but they all don't. They all say they try, but without requirements that relate to funding, without accountability, based mainly on what the payers, or the people who pay for that care, have in place. So even though you might have policies and procedures, if you don't have national standards with some teeth in it that relates to more than likely reimbursement, you're not going to have the total response that we need in our private non-for-profit healthcare systems. Another issue that we have is the lack of enough minority African Americans who practice in our healthcare systems, whether that's nurses, physicians, and other healthcare providers that are from the communities that we serve. So we know that when providers, speak the language and know the culture, and equally important, have the heart, really care. Not that others don't care, but really care about the individual, that's sitting in front of them. You do get a different kind of care, and you get better outcomes. So that's another thing that is missing in our larger healthcare delivery system. I know here in Michigan, we are graduating fewer African American physicians than we did 10 years ago. We are seeing a decline. There are fewer African American nurses, registered nurses, graduating than a decade ago. So a lot of these numbers are going in the wrong direction, and it doesn't bode well. So there's a huge role they've got to play, even though I'm a strong supporter of birthing centers and other options, choices that all women should have, especially African American women. We still need responsive, high quality, culturally relevant providers and health systems, because that is where the majority of babies are delivered in this country.
Well, Vernice, thank you. I'm going to turn now to Kylie. Kylie Lease, good morning or good afternoon, and thank you so much for joining us today.
Thanks for having me.
Oh, great. Well, your current research, and thank you for all of the great work that you're doing over at UIC, my alma mater. Your current research focuses on the health system structure and obstetric. I always like fumble on that word, obstetric. Help me out.
Obstetric racism.
I get tongue twisted at that. Racism, right? That drives disparities in maternal morbidity and mortality. So I want to know from you, Kylie, what have you found so far as the most significant health system barriers for women of color?
Yeah, great question. And thank you for having me. I think there are two main barriers that are like completely impossible to disentangle. And the first is that we have a very decentralized and uncoordinated healthcare system, so that when you have any type of issue, the onus is always on the patient to be able to navigate this very complex healthcare system where, and depending on the resources that are available, that's where women fall through the cracks. You know, that it's not connected in their chart that someone is postpartum when they show up in the emergency room complaining of chest pain. And so the emergency room physician doesn't think to ask whether they are postpartum, and then doesn't also have the information in front of them to know to think about whether this could be a postpartum complication that, that they're presenting with. And this is especially true for Black women, for women of color. I think that links into the other part, which is the racism, which obviously Bernice spoke about beautifully. You know, this idea that it's in an uncoordinated healthcare system where you're receiving lower quality care to begin with, and that racism begins not just at with the patient and provider relationships, but from people checking them in, you know, nursing. It's kind of at every level, so that it really is this molding of structural and interpersonal racism that what we've heard from our participants and from our patients creates a system where where Black women can't trust the healthcare system that they're meant to participate in. They don't have, it's really geared much more towards the providers, and particularly in perinatal care, it's geared much more towards the babies than necessarily following birthing people, and in particular birthing people of color and their needs through the pregnancy, and prioritizing that patient-centered care.
Thank you. And Kylie, as you know, Illinois now has a law in the books that beginning next year will require implicit bias training for healthcare professionals as a requirement for licensure renewal. Do you feel this is a step that will help address the roles that racism and discrimination play in maternal mortality rates? Are you aware of examples in other states where there has been a significant impact?
You know, the thing about maternal mortality rates is that no single intervention makes a significant impact. And that's really where our program is designed to be a really multifaceted intervention, because one thing won't do it. I think acknowledging implicit bias at the state level is really important. And I'm glad to see some actionable items in that realm. I don't necessarily know that, you know, whether the quality of the trainings and doing an online training once a year for someone who really harbors, and we all do, but a provider who really harbors implicit bias, how that's really going to impact their ability to care for pregnant people of color. But, and it doesn't change the systemic parts, right? It doesn't really influence how this is built into our systems. It's built into the legacy of our healthcare system, and including the ways that Bernice spoke about with redlining. I mean, Chicago is a great example of places where redlining has really, you know, it's mapped onto our disparities in everything from COVID to maternal mortality are grouped by neighborhood based on this redlining that was done, you know, a century ago. So I think it's great that there's an acknowledgement that, and it's a public acknowledgement, but I would like to see more done at the systems level to be able to actually unpack some of the implicit bias. And there are, Karen Scott and others have some really incredible tools to actually where they come in and do an evaluation in the hospital of obstetric racism, looking at the notes, looking at the supportive care, the providers, and then do an individualized plan to address it. I think we might have to invest a little bit more than just implicit bias training for recertification.
Yes, thank you. So Kylie, recognizing that racism is a significant factor in maternal mortality, has your research identified opportunities for improving outcomes? And I also, want to know, what is the role of midwives and doulas, and how do they differ?
Great question. So I'll start with that. Midwives are healthcare providers that are licensed by the state, and their scope changes depending on what state you're in, but can provide independent, full practice authority care to women, to birthing people from throughout the reproductive lifespan. So in a hospital, a midwife can catch your baby. They order your meds. They, depending, when I worked in Alaska, we first assisted on C-sections. We did a doula is a support person, and a doula is trained really to support the birthing family, to help them advocate for themselves and to support and understand their needs throughout pregnancy and postpartum. I think our research identified a little bit of what I said earlier, that it's not a single intervention, but that if we're going to address maternal mortality, we need to do it from beginning to end. And instead of focusing on individual level etiologies, hemorrhage, or even just saying mental health disorders, that we need to set up we need a new paradigm shift. We need a model of maternity care that actually centers the voices and needs of birthing people of color. And so I would say the first thing that we need, as I'll echo Bernice, is we need more midwives of color. We know that when birthing people have midwives, birthing people of color have midwives, they have better outcomes. We know that that people are asking for midwives who look like them and providers who look like them, because the trust is really lacking in the relationships that are not concordant. And I think that would I think that would have a large impact, or start to the impact as a systems level change, if patients were able to have providers of color, midwives in particular, and then doula support, not just in birth, but throughout postpartum, to be able to be that connection back to the healthcare system.
Thank you. And just, one last question before we move over to Laurel. Kylie, according to the Centers for Disease Control and Prevention, almost 2/3 of pregnancy-related deaths are preventable. And we talked about that earlier. I alluded to that. An examination of maternal mortality data by the Commonwealth Fund shows 52% of maternal deaths occur after delivery. So given this number, is there something in the healthcare system that we need to change regarding care after delivery?
I would immediately think, what care after delivery, right? We tend to, and this is part of the way that we've really focused intrapartum and perinatal care around the baby and not the birthing person, is that we've moved to having 2 visits, or maybe a telehealth visit and a postpartum visit for the mom. But essentially after 6 weeks postpartum, all the focus goes to the baby, and there needs to be seen as a dyad, right? As a dyad, a postpartum person doesn't stop being postpartum at 6 weeks. I have a 3-year-old and I still think I'm postpartum. I think that it's especially understanding that 12 months after delivery are crucial. And this is where we need to stop focusing just on the centralized healthcare system, but think about the ways that we can engage communities, and particularly community-based doulas, community healthcare providers, to be able to work with birthing families to link them back into the healthcare system. So in our project, we have Black doulas supporting our Black moms up to 12 months postpartum. And those Black doulas have a nurse navigator, on speed dial. So if they see their mom and something doesn't seem right, they don't have to make a healthcare assessment, but they have someone to call that's in the healthcare system. And our hope is that, when we talk about things like mental health being a leading cause of death, especially among birthing people of color, I think we think about that as like depression or anxiety, but really it's linked to social determinants of health and structural racism, right? It's suicide, it's use of substance use disorder. It has to do as much with domestic violence as anything else. And so instead of thinking about it narrowly as how do we address mental health, it's how do we build a safety net that really carries, especially Black women, from the time that they're pregnant through especially the first year of being a mom.
Absolutely. Thank you so much, Kylie. Laurel Mayer Neal, good afternoon. And I just need Laurel, are you unmuted?
I think I am trying to.
Okay, I think you got to hit that mute button. There you go. I think I got you. Good afternoon, Laurel.
You can see me. I don't see myself. I'm not used to this forum.
It's okay. It's okay. We cannot see you, but we're gonna keep moving along, because I think
Okay.
the important thing is that we hear you and we hear your voice. So I wanna get into this conversation of prenatal care, and so recognizing the importance of that prenatal care. How do you convey prenatal care, including nutrition and lifestyle information, to the pregnant individuals you support? Do you feel there's a gap in the healthcare system regarding this communication?
Well, in an ideal world, you would address those issues at the first prenatal visit and ongoing. However, sometimes it doesn't always work that way. You always address what their dietary intake is. Do they smoke? Do they drink alcohol? Things to avoid, things to increase. And then, we refer to all our moms to the WIC program, which that also helps. And then if needed, there's always a dietitian that we can refer patients to. But I think there's a gap. Absolutely.
Okay, and to what degree do you find language or perhaps an unwillingness to engage with the public health system an issue regarding maternal health?
Well, I think that's a big factor, simply because if you cannot communicate with your caseworker, you may not want to go and apply for public aid. And then if you have that fear factor, you're not going to have insurance. So you may not show up until you are in labor with no prenatal care, essentially.
Yeah.
So some of the issues that should have been addressed, early on in the pregnancy were not.
Yeah. Well, Laurel, in your experience, how important is the postnatal relationship between the mother and the healthcare provider?
Well, I don't know what more to add, because those two women really hit the nail on the head, because, nurse midwives make a change. They have made a change. I've been practicing for 28 years and I worked in the inner city of Milwaukee, and I know we made a change up there. And they were primarily African-American women. They have a trust with you. They bond with you. And we address not just the physical aspect. We address the emotional, spiritual aspects. Actually, it's the whole being. So I think that's important, is to incorporate the whole person.
Mm-hmm. Do you have some suggestions on how to strengthen that connection and sustain it through the perinatal period?
Well, I think we need to have more nurse midwives in the field. I think more African-American nurse midwives. I was a director at a previous another hospital, and I had two African-American nurse midwives. And I work in Chicago, and we need Chinese nurse midwives, because there's a large population of Chinese women. I think that would help. And I think doulas would be, because I know there are some practices that have doulas and they employ them. And also case management, all that helps these women.
Mm-hmm. So in your experience, are there challenges that commonly come up in the prenatal period, in the perinatal period, right before and right after birth, that are linked more closely with maternal mortality?
Well, I think that a lot of times they won't take their iron. Now, iron may not be a big deal, but if you come in and your hemoglobin is, if you're severely anemic, you have more of a chance of hemorrhaging, which is not a very good thing. Or if you come in and your bag of water broke 3 days ago, you're already infected, and so is your baby. So teaching is extremely important. I also think that centering pregnancy would be an asset as well. And it's been shown that really helps a great deal.
Thank you. Thank you. I'm going to invite our participants, if you have any questions, that remind you to please put them in the Q&A box. We would love to hear from you. So we're going to keep monitoring that Q&A box. In the meantime, I'm going to open some questions up for all three panelists. So this, please feel free to jump right in and answer any of these questions. But I definitely want to hear from all three of you. And I want to start with telehealth. And I want to know from, either, please feel free to jump in, but what role does telehealth play in reducing maternal death rates, and how should it be constructed?
If I may start first, I almost wanted to change your question a little bit to say technology. Telehealth is just one piece of how technology comes to play in these issues around maternal mortality. And I would definitely mention that for access, for communication, even your lowest income families have cell phones, and are on social media. And so communication is constant, but who is communicating what? So healthcare needs to be more intact with that. I know that doulas, for example, are in constant communication, with the mothers that they work with. They're all on social media. One of the things that we've done in Detroit area is we've created some videos on vaccines focusing on African-American women. And we know that African-Americans tend to listen to people like them, people from their community. And we're going to put those just in the chat if anybody wants to look through those, that we've done. We've also created a website called Detroit Health Equity Resource. We put that in the chat also if you want, data or research, which includes technology and training that can be done right online. That's very important. So we have to learn how to take advantage of all the opportunities that technology allows us. And telehealth visits is just one of the many opportunities that we need to take advantage of.
Okay, thank you. Thank you, Bernice. We talked a little bit about home visiting, and I want to hear from the panel, what role does home visiting play in reducing maternal rates, and how should it be constructed?
I'd be happy to take that one. I think it's fundamental to reducing maternal mortality rates. And I think it's not just home visiting, it's really thinking about making sure that these are community members that are trained and that are supported and that are paid well to do the home visiting. And when we talk about the infrastructure for that, Illinois passed a bill last year in order to support Medicaid reimbursement for postpartum home visitation, which was wonderful. They're still working it out, but within that, there were all these questions about, well, who qualifies? And oftentimes the who qualifies ends up falling disproportionately for white families, right? So it ends up being, how do you qualify a postpartum doula that has a DONA certification on the north side of Chicago versus a community-based postpartum doula who's been doing the same work, or if not more, within their community for decades, but doesn't have that certification. And so then how do we structure the Medicaid reimbursement to be equitable and to really focus on the communities that would benefit from it? But I think having trusted home visitation that can support not just coming in to make sure to weigh the babies, and not just to focus exclusively, really promoting breastfeeding, although obviously we want that to be part of it, but that can actually be have a doula relationship with the birthing families, a trusted relationship, so that that's someone that they could say, hey, you don't seem right today, what's going on? I think that's fundamental. And I'm really glad that Illinois is taking steps to actually put that within the infrastructure for the healthcare system.
Great, great. As the prior slide shows for Illinois pregnancy-related deaths in 2016 and 2017, mental health conditions are identified as the #1 cause of death. To what extent do we need to revise maternal care to include services related to mental health?
I would like to respond, but I'll wait for somebody else since I've responded once. But I would also like to respond.
Well, at Levio, we every time the mom comes in, we ask them the questions from the PHQ, and we also do the GAD2. We do that every time the mom comes in. Of course, sometimes they may not always tell you the truth. And then if they read a certain number, then we can also refer them to a behavioral health specialist that, we have also on staff.
Yeah, adding to that, there are screening tools that should always be used to screen every pregnant woman, person, for mental health issues. And one of the things that we are trying to do within our collaborative is to be sure all providers are using those. That's extremely important. And on the advocacy front, there's a huge shortage of resources and adequate places for women, pregnant women and others that are suffering from issues around substance abuse. And you note that substance use disorders is included in mental health. And that is a huge problem in our state, more so in rural areas actually than in urban areas, more of the white mothers than the Black mothers. So there's a resource issue, and there's a lack of attention and using the screening tool, so that you have to ask those questions. You cannot assume they're going to be volunteer.
The only thing that I really want to add to that is just that I agree that we need to do more screening. One of the things that I've noted at our healthcare system is that we do a pretty good job of screening. We have, sorry, my son just came from school. We do a pretty good job of screening. We don't have good mental health resources in the community or in the healthcare system. So even when we screen someone or someone screens positive, what we have available, especially if someone doesn't have private insurance, isn't sufficient. So I think it's recognizing, it's one thing to say that we need to be able to recognize and identify the people that need help, but we absolutely need more support actually enacting the help. And that means going beyond behavioral health and really thinking about if it's substance abuse, and then what kind of facilities do we have for rehab? What kind of partnerships do we have in the community? But thinking about mental health really in a community focused way.
Yeah, absolutely. Absolutely. I want to ask about birthing clinics, and I want to know what role do freestanding birthing clinics play in addressing inequities?
Well, you have to meet a certain criteria to go and have a birth at a birthing center. You can't have twins. You can't be doing a VTOL. You can't have a hemoglobin less than 10. And typically you're going to stay 12 hours and you're discharged. Therefore and there's no IV, there's no pain medication. You're not going to get probably a lot of teaching done there. I mean, these are for moms who maybe are on their second or third or fourth baby who don't really need a lot of hand holding.
I'm going to very respectfully disagree. I actually think birthing centers and community-based birthing centers are really powerful tools. We finally are opening a birth center on the south side of Chicago. In the last few years, we've had 3 pop up, in North Side and in the suburbs. But the whole point of the Southside Birth Center has been to create a place where Black women can come and be seen by Black midwives. And, I find, especially for first-time moms, that it's a great resource because there's more focus on teaching. There's more time taken with each appointment. There's more ability to cater services. We have another birth center, PCC, that's an FQHC, so a federally qualified health center. So focusing on, available to low-income moms, but actually being able to offer those services. So when you talk about better outcomes with midwives, part of that is recognizing and keeping things normal and providing care to the whole client. And I think that birth centers do an especially good job of that for people who are available, who they're available to. Yes, you can risk out of a birth center, but it's pretty amazing when you offer that level of care to moms who have other risk factors, for people who qualify. That I think it's an incredible and empowering tool.
And I was only addressing the delivery and birthing aspect. I'm fully agreeing of the antenatal aspect.
Sure. I agree too, that birthing centers are really an essential component of choices that women need in their communities. They need that choice. They need to be able to make that choice. Birthing centers have been proven to be safe. We don't have any in Detroit. So, one is in the process of being, we do have one, but they don't have a facility for delivering babies. So yes, it is an option. It is particularly safe for Black women. And unfortunately, hospitals are particularly unsafe, and as we look at unnecessary C-sections and things of that nature. So it needs to be added to the continuum. It needs to be safe and of quality with the right providers. And our hospitals need to be a lot safer for Black women when they deliver.
Mm-hmm. And this question is for any of the panelists, but are you seeing, or are there mental health services, when you talk about, the whole, quality of care, are you seeing that at birthing centers in terms of post, or how can that fit in, right? How can mental services, do you see that partnership, right, happening where you have sort of mental health providers sort of linking up with some of the birthing centers and recognizing, stress, anxiety, all of these things that come about when women are taking that journey?
I'll start out. I always have something to say here. Focusing on birthing centers, but I think you might want to focus on the doulas and the midwives. The birthing center is just the location where they stop for 12 hours. The doula is with that person throughout their entire pregnancy and afterwards, and will definitely be communicating, screening, not so much by a tool, but just by being a part of the family and a part of the community, and would definitely be making appropriate referrals and follow-up and support, for any mental health issues that might come to play. I don't know if birthing centers necessarily have that. They are hardly there long enough other than to be screened in a birthing center when you look at the entire, perinatal experience.
But prenatally, do they offer those services? I can't address that. I was just wondering.
It depends on the birthing center. I think that's they offer the same services oftentimes as other healthcare systems. But I think the other key part is that birthing centers are a way of thinking about perinatal care that's a little bit different than just the traditional medical model that hasn't served particularly women of color very well. So part of birthing centers, and this is something that Laurel mentioned that I think is really important, is centering pregnancy. Centering pregnancies, doing prenatal care in a group of 8 to 10 women with a similar due date. In our project MGMC, it's all centering pregnancy for Black women by Black midwives. And linking into that, some of the comments about technology, we're trying to, the groups have their own WhatsApp group so that you're building community and social support in ways that I think really supports mental health. And that's, so whether it's centering pregnancies or birthing centers, what we're all talking about are options of choice for Black birthing people and being supportive in a more community-oriented fashion.
Mm-hmm. Absolutely, absolutely. Well, we are coming to the end of our program, and I want to allow each panelist to have some parting words for our participants today. And so I'm going to start with Laurel. I'm going to give it to you. If you can give us some parting words, 60 seconds or less, you have the floor.
Oh, I've thoroughly enjoyed this session. I've received perspectives from these two women that have been out of my brain for quite some time when you're so busy just focusing on putting one foot in front of the other, trying to get through your day. I want to thank you for offering your advice.
Well, thank you. Thank you, Laurel. And Kylie.
I would actually really like to yield my time to Bernice because she's way more of an expert in this than I am.
Well, no, you have your parting words. I'll wait for you.
There's nothing that I'm going to say that you don't say better. Then please take the time.
I'll go ahead and comment, and you can comment afterwards. First, I want to thank you all for the opportunity. I really enjoyed it, and I too have learned some things, by listening. And I think that that everybody on this call, and certainly the panelists, we all have a role to play. We all have a power to make some type of change, in all of these issues that we talk about. So I just kind of want to encourage people to really think about where your place is in pushing the button, whether you're sitting at a university or you're a midwife or you're a social service provider or a leader such as the advocacy. Everybody needs to get involved in advocacy. Everybody needs to get involved in advocacy. And you have this great organization that brought us together that's focusing on advocacy and healthy children. And we do advocacy in my organization. So I want to just encourage everybody to think about your role and get engaged in advocacy. The one other thing I wanted to add is that also I shared, on the link, a recent report on COVID and African American women in pregnancy that was just released by our state health department about 3 or 4 weeks ago. So it's some very recent data that relates to pregnancy and COVID. And again, the huge disparity is there. So, just check the chat for some of the resources that I offered.
Thank you, Vernice. And Kylie, I know that's a tough act to follow.
Yeah.
I don't even want to say anything. I just want to end it, but I'm going to give it to you.
Oh.
Over to Kylie.
The only thing I guess I'll add, I put in the link for the project that we're doing. It's Melanated Group Midwifery Care. It's a randomized control trial that's looking at what happens if you reconfigure maternity care to be trustworthy and centering the voices of Black women. So it's racially concordant care, group prenatal care, Black nurse navigation, and Black postpartum doula support up to 12 months postpartum. So I hope maybe we'll come back sometime with some more data on that, but I just wanted to give that a little plug.
Well, thank you. And I want to thank you, all of you, for this wonderful discussion. This has been absolutely amazing. And I certainly feel like we have to have a part 2, because there's so many things that I think that we can, drill down on and have more deeper discussion, because we're all in this to bring the maternal mortality rates down. We want them to go down. We want our babies to be healthy. We want our mothers to be healthy. We want them to be supported mentally. And so we have lots more work to do. We have a lot of conversations to do. And so I want you just to keep an eye out for more coming from children's advocates for change. Thank you, Vernice. Thank you, Kylie. Thank you, Laurel. This has been an amazing session. So thank you. Thank you very much. And so I want to encourage you. There's lots of wonderful links in the chat, and I want to thank our participants. Thank you for showing up today. We really appreciate you. This has been a wonderful conversation. But we also want to just give a plug for our next forum, which is coming up next week. And it's coming up on Thursday, December 15th. And we're going to talk about family economic supports. And we're going to hear from Mitch Lipson. Mitch Lipson is a vice president for public policy for Children's Advocates for Change. And he is a superstar when it comes to public policy. He cares very deeply. So he will be joining me to have this discussion. We will have U.S. Representative Susan Del Bene. She's from Washington, and she's the chair of the New Democratic Coalition. We'll have Illinois State Senator L.G. Sims. We'll have Dr. Valerie Wilson and Dr. Christopher Weimer. So please join us. Please register. The link is there. Visit our website at children'sadvocates.org, and the registration link is there for you to click on. So thank you very much. You guys have a wonderful, wonderful day and enjoy your holiday.